Good evening, all. I welcome you all. This is a great evening. This is also a digital dentistry. Instead of sitting in classroom with blackboard and chalk piece, we are in a digital meeting. So, without wasting much time, I would like to introduce Dr. Manasa, who is practicing in KK Nagar, the backbone of Halodent and Dentalvriksha. Dr. Manasa, over to you. You can host the evening, please. I would like to request you to introduce Dr. There is no need for introduction actually, for Dr. Arunachalam anyway. This is a protocol, so please introduce Dr. Arunachalam and then you host the meeting, please. Over to you, Dr. Manasa. Thank you.
Thank you, sir. So small introduction about our speaker today. Dr. Arunachalam sir is a well-renowned practitioner with keen interest in periodontology, implantology, and digital dentistry. Sir has delivered more than 200 lectures till date. Arunachalam sir has completed Masters in Dental Surgery, Masters in Business Administration, and also is a Fellow and Diplomate in International Congress of Oral Implantology. His digital skills include restorative design, implant planning, 3D printing, aligner design, and ortho appliance design. Sir. Thank you so much, sir, for agreeing to share your knowledge with us, sir. Over to you, sir, for the presentation.
Hello, good evening, everybody. Are you all able to hear me clearly?
Yes, sir. Yes, we can hear you.
Okay. Thank you, Dr. Mansa, for your introduction. Thank you for being so kind, and thank you, Manik Vaskam, for allowing me and sharing this platform for me, and giving me an opportunity to share some of my views and thoughts with you. You've been a friend for so many years, and
Thank you.
Really thankful for this opportunity and appreciate communicating with all of you. So let me just go ahead and launch the presentation. Anyway, thank you, Manik Vaskam, once again for this excellent opportunity. And like you had suggested, this is a program on digitalization in dentistry and how digitalization is affecting every single facet of dentistry today, including right from the very manner in which we have been taught to diagnose, we have been taking records, or we have been delivering a prosthesis or delivering some form of a restoration or going ahead with the treatment itself. So basically, for want of another term, I think analog is probably the opposite of digitalization. Since there is no real term, analog dentistry, digitalization is basically how technology and innovation has advanced the way in which we are, working today, and that is and how it has overwhelmed the way in which our day-to-day life itself matters. So first of all, I assume most of you are practitioners here, and all of us want to have very good practices. And some of the key approaches to having a good practice, and this has been around for ages, through the entire management of a practice, has largely depended upon providing a good quality clinical care, having excellent communication, having very good relationship with patients, managing your practice efficiently and effectively, being time efficient, being competitive, and giving the patient the wow experience inside your practice. In the modern practices today, not much has changed, but all of these objectives are getting met by the use of technology. Not only are we looking at technology in terms of how it runs our day-to-day life, but also being able to provide things faster, cheaper, better, having a comfortable environment, having time, for patients to come in and attend, having good location, having good hours of practice, having excellent staff, having a clean and a safe environment, which are all priorities for many patients. How digital fits into this common concept of having a good practice practice and the modern practice is that it provides us with lots of tools and lots of techniques for us to run our day-to-day life. It's extremely accurate and precise. It's very fast and efficient. And at the same time, it keeps patient comfort at a platform which is much above whatever you might have seen until now. So coming from there, what are all the things that we can do from the digital perspective today, or what is it that is overtaking our day-to-day life in terms of digital perspective? In our day-to-day practice, these are some of the 5 technologies or 5 techniques that we might be talking today. The first is digital imaging, and these are very, very common today. These are happening as we speak. It's become routine, commonplace in most practices. So digital imaging is one thing. Making a digital impression or an intraoral impression digitally is the second thing. And how you can transform the data that you have acquired either through imaging or through impressions into your fabrication of your day-to-day restorations, how it impacts the way you have been probably practicing every single specialty of dentistry, including orthodontics, implants, or perio, or endo, or what have you. So this is just a primer. This is a concise information about how we practice in our practice day to day, and how it has basically changed the way over just even the last 5 years or so, how it has changed the way that we practice. So first and foremost, as far as digital imaging is concerned, intraorally we'll come to that. But most often we are looking at the hard tissues like bone and teeth. And for that, uh, we are really familiar with radiovisuography in terms of both sensors and plates. We're also pretty familiar with orthopantomograms, which are almost entirely digital today. They used to be analog orthopantomograms, believe me, when I say that. And of course, today we have digital cone beam computerized tomography also. So if you looked at the manner in which an orthopantomogram is taken, we assume that the orthopantomogram is a single image or a single image that is taken as the orthopantomogram machine goes around us, but it's actually a series of clicks. So if you look at this, there are at least 1, 2, 3, 4, 5, 6, and 7 sections, which are individual radiographs which are taken by the OPG machine, and these individual radiographs are merged together to create a orthopantomogram. The thing with the orthopantomogram is it has a focal trough and a center point of focus. So we get a single position wherein we have to, which is the most appropriate position for that particular patient, or which is the most common position for that particular patient. And how we arrive at that position is through the landmarks the orthopantomogram machine allows us to set, like a canine level, and then the level at the level of the infraorbital foramen, or at the alar tragus line, whatever. There are laser markings which helps us to position the patient in such a manner that we get the perfect focal trough. But then the panoramic arch of many of these patients is different, and so in some orthopantomograms you'll be able to see the canal very well, the mental foramen very well. You may not be able to see the teeth very well, and there's also the concept of some inaccuracy, some elongation, and some distortion of images. Whereas if you look at a cone beam CT, it's still a 2D panel sensor, but you get to see volumetric data because there are a large number of sections, a large number of radiographic images that are being taken serially, and then they can be mathematically modeled into a 3D form where you can have a coronal, axial, and sagittal sections all merged together. You can walk around them, and all of these can be superimposed one on the other, and the different orientations to these can be made. And so you can have a 3-dimensional image, so to speak, of your entire process. Not only is that important, but also the level of distortion is very much reduced. There's hardly any distortion in many of the CBCT machines, and it is possible for us to get volumetric data at quite a lot of speed. So the applications here are mainly in implants today, also in pathology diagnosis, in endodontics, perio, oral maxillofacial surgery, ortho, in the fabrication of surgical guides, temporomandibular joint disorders, etc. These are the series or the number of cases. If you see, mostly for implant planning, the most people use CBCTs for implant planning, also for post-operative evaluation, and then for CAD/CAM, and then endo, and I don't know, in Chennai or in other places, I have found people using CBCT somewhat lesser for endo, but in Bangalore and many other cities, slowly Chennai catching up as well. Most of the endodontic diagnosis today, most endodontists insist on a small CBCT machine for them so that they get to see, they don't miss any canals, they get to see the varied pathology of different teeth, so on and so forth. So as far as surgery is concerned, it helps us to localize the nerve. It helps us to know the exact location of the inferior alveolar canal with respect to the apex of the tooth. It helps us to know whether the roots are in contact with it, whether the cortical plate is touching the root, whatever it may be. And what is the exact three-dimensional position? What is the position in the sagittal plane? What is the position in the axial plane? What is the position in the coronal plane? So all of these things will give you a much better understanding of where the tooth is. An impacted tooth is an enigma. Essentially, not all impacted teeth are the same. Every single tooth presents you with a challenge, but the more information you have right at the beginning of the procedure, the more prepared you are, the less risk there is to the patient. The patient has excellent comfort, etc. Also, any other pathology in terms of cysts or anything can also be localized very, very well. We can see what is the equation or relationship of the nerve with respect to the cyst, and whether we enucleating the cyst, or we are likely to produce a paresthesia, or should this be for marsupialization. Any decision making can be done as long as you have more information. The TMJ examination has always been quite a difficult thing in most part dentistry for most periods, but with the cone beam CT machine, and if you do have the correct positioning of the patient in a good field of view, then you will be able to get very good temporomandibular joint pictures as well, which will aid in the diagnosis of any temporomandibular joint disorders. If you're doing surgery, including implant surgery or sinus lifts, it can help you assess the volume of the sinus, what is the volume of the graft that you will be able to use, so on and so forth. And so this is a good thing. You can also assess pathology inside the sinus. You can see if the sinus is septate, if there is any other deviation, whether the ostium is open. There's lots of information that can come, which will help you decide, can I progress with a sinus lift for this patient, or is there any other alternative that I have to think of? Or so does this patient need an ENT consult beforehand? As far as endo is concerned, one of the most accurate methods to calculate the working length can be obtained with the CBCT. Not only that, you won't miss any canal if you are keen enough, and if you are very, very meticulous in following through every section of the CBCT, then you will know. You will also know whether post-operatively your root canal has been three-dimensionally filled, whether there are any spaces, have you crossed the apex, so on and so forth. It's an invaluable tool as far as endo is concerned. More importantly, in the practice, and also we do it for some endodontists, if there is a big calcified section, mostly in the anterior teeth, we are able to create a three-dimensional model out of that. We are able to pinpoint the location of the axis of the pulp chamber and eventually the root canal system itself, and we can provide a drill of an appropriate length. In this case, it's a 1.2 diameter drill, which can be used to exactly access or create a path where you are going straight into the canal itself. So which means that if you create a stent like this, if you create a guide like this, a custom guide, you will have a drill which is exactly 1.2 millimeters opening with the 0.05 millimeter play, and then you will be able to access the canal. You can establish the depth, and you know to what depth you can go. You can create this extension which will let you not perforate, which will let you not go beyond where you have to. And as soon as you have done that and you have cleaned up that system, you'll automatically be able to access the root canal system really fast. Root fractures, very important in diagnosis. Excellent tool in diagnosing root fractures as well. In orthodontics, the usefulness of a CBCT is in many ways, both in treatment planning. Today, you have customized brackets, customized wires. Also, for us to know whether any of the roots are touching the cortical plate, whether anything needs to be done, or if we are going to move this root out of the cortical plate. This is very essential information in ortho, and also for the evaluation of impacted teeth. It's a great tool. In perio, extent of bone loss, the nature and shape of defects, whether they are three-dimensional defects, how many walls are available for us to do a grafting if we have to, How vertical are these defects? How many are they? How are they amenable to grafting? Is there any labial cortex? Is that lost? All of this information, if you spend enough time, you can gather that information. So where is this? So what type of a CBCT would you require, or what would you order for? Essentially, we look at only 2 or 3 different fields of view. The first one is a small field of view, which we will call a 4 by 4. And we get this field of view. We use this 4 by 4 view for endodontics. We also use it to localize periodontal problems or localized implant problems. And the next view which we use is usually in 8 by 11, where we can do a single full arch assessment, or a triple scan 8 by 11, where we can do a complete dual full arch assessment. There are, of course, larger FOVs that we can use. 10 by 10 is one example, which is more 10 centimeters by 10 centimeters, is like a squarish field of view. But with newer technologies and with robotic arms on most of the newer CBCTs, you are able to superimpose images without any defects at all, and able to get both the joints bilaterally, even for a white patient, bilateral joints on a triple scan, on a single scan itself. So the commonest, most practical FOV that you use is an 8 by 11 with a good superimposition. And then a 4 by 4 is usually for endo. The resolution of a 4 by 4 is much better. You get up to 75 microns of resolution, whereas on an 8 by 11, it's usually 100 to 120 microns. So many a times we can gather information like this by superimposing different areas. Like there can be a dual scan where part of the jaw is scanned first. There's a second scan with the patient remaining in the same place. There is a motion artifact detector, which basically stops the motion artifacts. There is and merges both of these data. So you're on a single sheet, you can get all of the data perfectly enmeshed into each other. So much for CBCT as a diagnostic element. I mean, today the most practices in our practice, almost every day we usually have a few CBCTs taken. Most of it is for implant planning. Some of it is for endo, but most of it's for implant planning and oral surgery. But it's the norm today. We would not operate on a case where we suspect that there could possibly be a neural involvement, or if you're doing an implant, definitely a CBCT, because we'd like to get a 3-dimensional information and also create a guide, which you will see during the course of this presentation. The next component is about digital impressions. Now, so far, we have been very fascinated with rubber-based materials and alginates, and we had a plethora of impression materials. But today, we have moved completely digitally. The entire mouth is scanned with an intraoral scanner. And this is either a video type of scanner or a photographic scanner. And all of these images, which basically takes a 2D image. And then as you move the scanner, you get a Z-axis or a 3D interpretation of that distance by triangulation. And you get a 3D pseudo-realistic model of the teeth. It's not a real tooth, but it's a pseudo-realistic model of the teeth. But then that data is completely digital data. It can be transferred. It can be merged with other CBCT data. It can be merged with other STL data, or solid stereolithographic data. It can also be used to transmit information through email. So you can actually transmit the impression through email. So you don't have the problem of dimensional stability of your impression material, or breaking of your models or casts when you're sending them to the lab, so on and so forth. So there are a lot of different types of CBC, intraoral scanners that are available in the market today. If you're choosing one, you'll have to probably look at things like, what is the scanning speed? What is the flow of scanning? What is the tip size of scanner size? How easy it is to use? What is the kind of software? How many times does the software need to be completely updated? And is there a cost attached to this updation? What is your investment cost? And whether there are any fancy apps like caries detection, or is it wireless, or is it touchscreen, so on and so forth. Every dentist has their own series of preferences. So depending on your budget and depending on what you want to do, you can choose any of these scanners. And there's so many available in the market. Most of them are really, really good. One of the other methods that we use in the practice is something called photogrammetry, where if we are doing multiple implants and we want to connect them all together with a bar, which is either printed or milled, then we use these small flags where basically we have some sort of a structure which is attached to these implants. And as long as a triangulation camera. Three separate cameras can detect that uh, that flag with those rings that you saw. It can have does have an internal algorithm which helps it to exactly predict the location of the implant, and that way we have the most perfect positioning or recording of the implant positions. Even if you make a jig, and if the jig is not a passive fit, you have to cut the jig, add some resin, and try to make sure that the fit is passive. Whereas with the photogrammetry, you get 100% error-free, passive kind of fitting restoration uh, because of the excellent algorithms involved in positioning the implants perfectly. Nevertheless, in all photogrammetry, you also need to do an intraoral scan as well. Well, once you have had all of these data, what are you going to do with it? From the restorative viewpoint, today we do a lot of resin restorations. These are printed resins. These are not composite resins that come out of your tube. These are printed resins. And one of the advantages of printed resins is that they have almost zero volumetric shrinkage. They can be very suitable for white cavities, and they are all ceramic filled. So in the ADA list of procedures, which are insurance, which most of the insurance companies use, these are actually classified as ceramic restorations. Today, you have ceramic, which is more than 50% filled ceramic resin. So, which means that you can create a chair-side restoration, which is a printed restoration. It could be an inlay, it could be an onlay, it could be a bond lay, it could be a veneer crown, it could, any of these options are possible. So the sequence here is you prepare the tooth and you scan, and then you design the prosthesis, then you 3D print the processes, you finish and polish and you bond. So like, for example, in this case, it's a badly mutilated tooth. So we build this up with some composite and bisacral, basically essentially composite. And then this is an endo crown, which means we create a small retention slot on the occlusal surface. So once this crown is scanned, and then we can actually design the restoration chair side. This is Exocad. So we can define the margins. The dentist is the best person to define the margin, because when you make an impression and send it out to the lab, it's a technician who has to guess the margin. So the dentist here knows where the margin is, and so he can design the margin. He can outline the margin himself. Then you design the superstructure tooth straight away. And once you have the superstructure tooth design, you can then go ahead and make sure that occlusion is okay, your contacts are okay, your proximal is okay, the depth of occlusion that you want to give, margins are okay. So, and then you have a recent morphology that you want to work with. So, and then you merged all of these smoothly and created a very nice, contour and contact for the restoration. So once you have done this, you can then go ahead and print this out. Before you print this out, printing is just like a regular office printer. You have an A4 sheet, you put it in, and the printer is a two-dimensional printer. Whereas the printers that we use are 3D printers, which means there is layer upon layer upon layer upon layer is printed. So these layers need supports. So you need to slice the entire three-dimensional option, and this is called a slicing software. So the slicing software helps you to slice this three-dimensional object into, say, 100 slices, 200 slices, 500 slices. Each slice can be anywhere from 40 microns to 120 microns. And you provide all of these supports. And once you provide the support, every single layer is printed one on top of the other as dictated by the CAM software or the manufacturing software, and then you have a completely 3D. Again, since every single 15 micron or 40 micron is being cued individually, there is hardly any shrinkage in any of these restorations. So these are some of the printers that we use. This is essentially a model resin, but there are many different plates that we use. We use small plates for small crowns. We use big plates for models, and you can print your model. You don't have to pour any models. There's hardly any shrinkage or because of your impression material or time lapse or whatever. And so the accuracy of all of these is extremely very good. So once you have the printed restoration come out, it just sticks out from the plate. It just comes off like that. Then you have to finish all of these individual crowns. So we first remove the unbonded, uncured layer using an isopropyl alcohol. So that's the restoration that comes out. So the uncured layer on top, there's always an oxygen present which is inhibiting this. Well, today there are also nitrogen containing curing units where you can cure the presence of nitrogen. But what this does is you do have If you're just curing it, in a regular environment, then you use an isopropyl alcohol to clean up that surface. We then eventually make sure all of that uncured resin is removed, and after that we can polymerize this. So this is the polymerization machine. So this is a very high intensity light machine with which we polymerize them. So eventually you get restorations like these, and then once these restorations are post-processed and done, you can finish and polish them just like what you would finish and polish a regular composite restoration. So use these greenies, brownies, whatever you have, a rubber cup polisher, so on and so forth, and then you can mark all your grooves and have your final restoration done. So that would be a final restoration that sticks out. And then all you have to do is bond these restorations. Remember, these are also composites, even though they are set 50% plus ceramic fill, they are composites. So all of these can be bonded on right onto the tooth. So we use our regular bonding procedure. So we wash, we clean it with the IvoClean, usually hypochlorite containing cleaning agent, so that if you tried the crown in the mouth, then salivary proteins are there. So then you can apply your silane or any other coupling agent, and whatever you choose, you apply sulfate to the surface of the crown, and eventually you can, as in you mix your cement, and you can bond these crowns directly onto the tooth. So it becomes a monolithic bonded restoration. And this restoration, the chances of an adhesive failure in this case is extremely very, very low. Okay, so so this is as far as resin restorations are concerned. The use of, we're all very familiar with MLS, but today the use of zirconium has become very, very common. Sorry. As also metal printing and metal milling. These are some of the metal printing, these are some of the milling areas where you see here zirconium getting milled, you have metals getting milled, you also have printed restorations, and you have combination restorations. So what I talked about, what you saw there, it's a little noisy, but what you saw there was a zirconium getting milled. You also saw metal getting milled. Then you saw a layer where you had a metal getting printed. So there are two small plates which you drop titanium or whatever you want to print, and then there is just a small layer of powder, metal powder that is there, and then a laser comes in, and the CAM software drives the laser, which helps to fuse these metal particles together and create a single structure. So layer upon layer of metal is added, and then eventually a three-dimensional print is done. And lastly, what you saw is a combination of that. Now, when you are milling something, if you take a block of a disc, say you take a zirconium disc or you take a metal disc, the angle of milling depends upon how straight. There are only certain things that can be milled perfectly. If there is an undercut area, usually the CAM software will block that undercut area and will not mill it. So that area will be relatively straight. So the accuracy of printing is much better than milling, because in printing, every single layer gets printed. Whereas in milling, only that can be cut or above the maximum contour. From that contour only can be prepared, however thin or however angulated your axis-wise your milling machine might be. So this combination or hybrid wherein you have a printed base on which you can further mill gives you the advantages of both. It gives you the perfect finish and accuracy of milling, while at the same time maintaining that every single layer is also done. The area that is changed also, that's as far as restorative dentistry and prosthetics is concerned. There are lots of things going on, but just a basic primer on what's exactly existing today. One of the big practice changes today has been aligners. I call this a revolutionary change in dentistry. Most of dentistry is evolutionary, which means that everything grows slowly over a period of time. You start with the, different types of restorations, glass enamels to amalgam to composites and so on. So different types of composites. But the way in which the aligner industry has moved on is revolutionary. It's been completely different mechanism by which this entire thing works. And of course, there are many products, aligners that are available. And then, of course, big industries are fairly involved in creating and providing you these solutions. And they work very, very well. I mean, industries are quite strong, and they have been very, very accurate, and you have the backing of a very, very big organization or a big company which helps you solve the case and handholds you throughout a 3-year period, 5-year period, whatever you may have. So the fact is that aligners are here to stay, and that's probably the direction in which orthodontics is going. In terms of the capacity of aligners, even though our usage here is somewhat limited to certain cases, but I have seen excellent practitioners across the world who do remarkable things with aligners, who also combine aligners with elastics and aligners with temporary anchorage devices and so on. So with the expansion appliances, we also manufacture expansion appliances for some orthodontists. So essentially what it does is that this is a plastic which has a flexibility and an elasticity, and that the elasticity of the aligner pushes the teeth into the position. In the case of a wire, you have a wire which is held on one end. It becomes like a spring. So the elasticity of the wire is the one which moves the teeth. The thicker the wire, the better engagement the wire, the better predictable the movement. In terms of the aligners are concerned, it is the nature of the plastic, the nature of the software which helps you to design your tooth movement, to stage your tooth movement, that helps you achieve the results in ortho that you would like to achieve. In terms of being able to engage, so like a wire, the thicker the wire is and the better it engages in the socket, gives you a much better application of the force in the point where it is directed. Likewise, if you have a very short crown, aligners are not as efficient. Whereas, and similarly, if you have a surface very homogeneous, the area where you have to apply the force is not the area which receives it. So you can have attachments. Attachment helps to engage the aligner much better. You have attachment which helps to hold the aligners in position. You have attachment which helps to move the aligner position. One of the biggest advantages with aligners is in terms of its predictability. If the patient is tracking properly, you can actually say this is the time and date on which you're going to finish your treatment. That is because the unwanted movements with aligners are very less. Whereas there is a lot of unwanted movement with wires and braces. Most of the time spent is spent in undoing the unwanted movements that happen with wires in traditional orthodontics. Whereas with aligners, entire segments can be stopped. Only certain segments or certain teeth can be made to move. And that advantage is a significant advantage. Of course, every single kind of tooth movement that you can imagine has been now being made available through the use of aligners. You want to extrude teeth, intrude them, give them a labial or lingual trough, incline grooves, whatever. Almost all of these are now accessible. So here, like I said before, you can do a selective section, like you can select a certain section which you want to move. You can grade and stage this movement. You can say, okay, look, I have a crowding. I'm not going to do any interproximal reduction with this level of crowding. I'm going to first expand, even if it looks worse, expand, make the teeth all contact points very, very close to each other, not overlapping one another, and then do my IPR, and then probably retract the tooth back. So this is a staging process, and that is definitely a good mechanism as far as aligners are concerned. Also, a good vertical control in many of these cases is possible. There's hardly any extrusion. Similarly, very specific points of application of force are possible. There are certain dimensions and shapes of attachments which help to direct forces in, which may be coupling forces, which may be straight pressing forces, and all of these are possible today. So it's just your imagination and the ability of the software to incorporate all of these that determines the final result, and of course the compliance of the patient. Okay, so yeah, so most of our cases today, though I would say that 50% is the level of progress in our own practice. 50% of our patients still go with wires and braces. Mostly these are teenagers and youngsters, but almost the entire adult population is entirely on aligners. And you would be surprised that there is a significant number of older individuals who are willing and happy to have their teeth corrected and want to have it done because today's life and lifestyle demands that kind of position. In the factory production of aligners, I mean, this is most companies today have a complete robotic automated mechanism of aligner production. And if you see here, you have a robotic arm, sorry, which selects the particular model, and then you have the sub down that's made on top of that model. It's sequenced, packaged, and sent to you. Hardly any human hand involvement in this entire process, and this is really, really fascinating for us to see. So like I said, it's been a revolutionary change as far as orthodontics is concerned, and that's a big plus for many general practitioners as well as the large number of orthodontists. Lastly, we'll talk a little bit about digital implant planning, which is again one of my favorite areas and my most common work in the practice today. One of the things with implants has been the learning curve. You know, how am I able to place an implant predictably? Am I the right depth, right mesiodistal angulation, right buccolingual positioning, etc., so on and so forth. But with a guided procedure, you can be absolutely very certain that your implant is in the most appropriate place. And I mean, you would agree with me that there's only one most appropriate place that an implant can be, and that place, if you can identify beforehand and create a custom guide for it, that's probably the best way to practice. So a simple workflow scenario would be like this. So you say, okay, I have a single implant tooth situation here, so I'm going to work backwards. I'm going to first start with the tooth and find out where the tooth is going to be, and with that tooth I will come forward and generate the implant, predictably position that implant in that place, custom fabricate a guide. And once I have custom fabricated a guide, I can, in many cases, it will let you do this incision free, which means if you have enough attached gingiva, you can just use a punch and almost blindly go ahead. I mean, in the initial stages it is actually a leap of faith, but once you develop more confidence in the diagnosis and in the treatment planning, and especially if you have directly been involved, then it's a very, very big step forward. And after that, you will never go back to routine freehand dentistry. I mean, I've been practicing implants for many, many years. But today, almost 100% of the cases I do with guided. There's hardly, in a year, probably 5 cases I will do without a guide. But this is mostly everything, even every single tooth is a guided situation. And because the long-term stability, the long-term prosthesis, all of these, sorry, are all largely by that position and that outcome of that far more predictable with the guided surgical procedure. So this is how a guide would be. You have a smooth portion of the drill which engages the slot, and then you just have to go full depth. I mean, there's really nothing much for you to do here. Full depth. Either you can place the implant with the guide in place, or you can do freehand. Many a times today I do with the guide in place. This was done quite some time ago, so this is freehand, but either way it works. Your implant is not going anywhere else. And then once you have done that, you can torque the implant to your adequate torque, whatever you torque. Then you scan it, provide a provisional temporary abutment, and then you print your prosthesis, because you have a printer right there. You print your prosthesis, and then your patient goes home with the tooth in place. Though it's a provisional, it doesn't come into occlusion, but at least the patient goes with the tooth in place. Now, many a times you're able to do that. I'm not saying you're able to do that all the time, but many times you're able to do that. And in multiple implant situations, like if you have an all-on-X type of situation, all-on-4, all-on-6, whatever, patient has a full-fledged prosthesis within 48 hours, at most within 48 hours. So that's a big plus point. So how does this computer guided work? You take a CBCT, you take an impression scan, intraoral scan, you do a software planning, you create a treatment plan, you create a custom fabricated surgical guide. There are a large number of software which we use for creating this guide, and your own choice, your preference is your preference. One of the things most of these softwares you'll have to do is something called segmentation. Now that AI has taken over the segmentation, now every single tooth can be separated out. You can see the socket here separated out, and you can print out each one of these individual tooth if you want. You can even print out the pulp if you want. So every single segment is digitalized and taken out. And Like for instance, if you have immediate extraction situation, you can extract this individual tooth and place an implant in that place. So segmentation is a very important element. And from there, if you are also having a patient who doesn't like the smile, or who's imminently going to lose many of his teeth, then you can plan it to the perfection by actually establishing a completely new occlusal plane, a complete vertical incisor show of the incisor, so on. So, like if you look at this here, we do an intraoral scan of this patient in occlusion, and then we identified all of these planes, the midline, the occlusal plane, so we can design a wax up to the position that the patient likes the tooth, wherever she likes the tooth. So we designed the digital wax up. This would be the digital wax up. We can superimpose even the pre-op on top of this and see how much change there is from the pre-op. So that would be a pre-op, that would be a digital wax up. So you know everything is aligned, and this alignment is done with the CBCT. So you know very well that this is where the patient wants to be. So having said that, we can plan the position of all of these implants perfectly. We can create and custom fabricate a guide so that the implants are at the exact position where you want them to be. So you can custom fabricate that. This is a stackable guide that we have custom fabricated. We fix the guide in the patient's mouth, and with the help of her existing teeth. So now you have a base guide. So this base guide does not let your implant go anywhere else. After this, you extract the tooth, do your osteotomy the way you want to do your osteotomy, and then go ahead and you can stack another guide on top of this. This is your actual implant guide. So this stacks right onto this base guide. So your implants are in the right angulation. If you see these small squares here, they tell you where the hexagon of the implant face is going to be. So if your multi-unit abutment, you have planned beforehand, 17 degree, 30 degree, whatever degrees, if you rotate and place the implant correctly facing that square, your multi-unit abutments will just go in and fix like a glove. So you won't have a significant difference. The same thing is done on the lower arch as well. And then you can position the implants, like this. You can print this temporary prosthesis. The patient can go home with the temporary prosthesis. Mostly because we do it a lot under sedation. We finish the procedure and we call the patient the next day, and by that evening the prosthesis is ready and the patient wears it, goes home. So that's how the situation is. So just to give you an example, this is a denture scan. So we have taken the denture, used that as a scan appliance, and identified points on the denture, and with the denture in the patient's mouth and the denture scan separately, we have positioned and planned the position of all the implants perfectly. This is where the implants are going to come. We know what are all of these are 0-degree angulated. So this is a stackable guide design. So this is your old denture. With the denture, we position the guide. This is the base guide. On the base guide, we have all of these slots where we're going to place your osteotomy and do the implants. This is where the implants are going to come. This is the after the osteotomy, and you have made the bed flat. So if you look at it, we print out the model, so we can actually do the mock procedure up front. So this is the printed version of the scan appliance. You see that these are the screws which help you fix the appliance or the base guide onto the bone. And once the base guide is fixed to the bone, you can position the implants, and the implants are not going anywhere. So if you look at it, you make your incision. This is the amount of bone that is extending outside. So you use the denture to position the base guide. This is the denture in occlusion. So this is the base guide. Once you have the base guide, you have any proud bone that is sticking out, you flatten it out. You have a nice flattened ridge now. And once you have a flattened ridge, this is the ridge that you have. Your next stackable guide goes and sits on top of this. So once the stackable guide goes and sits on top of this, all you have to do is make your osteotomies and position all your implants together. And once you got all your implants, you see that all the implants are perfectly lined up. All the multi-units are perfectly lined up. And that's all your healing caps. And this is the post-operative X-ray of that patient. So all of the implants in the right position where you want them to be. You can also create this window kind of a guide where you scan, because you've already taken the CBCT in occlusion, already done the entire process in occlusion. You now have the occlusion of the patient. You have a combined scan of all your scan bodies, right? Immediately after the surgery or the next day if you want to be. And once you've done that, you can then go ahead and print your prosthesis. So you see now your prosthesis is printed here. We try in the prosthesis. You can paint pink gingiva here if you want. And this is very well good, ready to go. Now I have fixed this provisional prosthesis using direct to multi-unit screws. There are special screws which help you fix this prosthesis directly to the multi-unit abutment itself. And the patient goes home with teeth. This is a very, very good service for the patient because it really improves the confidence of the patient. It really gives them, the hope that you're on to something and you're going to give them a restoration that's going to last them for a good length of time. So we do the same thing as far as this one is concerned. As we can also create guides for other situations like a zygomatic implant, and you see here we have created a guide for a zygomatic implant. And also the two anterior implants that are there. And we can, so at the time of surgery, you have these this we print out in metal because there should not be any deformation. So we print out in metal. We can create the path directly to the zygoma, and this is done in the chair. It's not like under general anesthesia or anything. So the patient is just sedated, and then you have you can have positioned the zygomatic implant. The most appropriate position is just a sectional zygoma, and then immediately post-operatively you can scan the entire area. These are the scan bodies in position. So once you have scanned, you can create a provisional prosthesis. Sometimes this provisional is porcelain fused to metal, and then this provisional prosthesis stays in the patient's mouth almost like a definitive prosthesis. Patient can change it whenever they want. So these are some of the things that that is possible. The same thing is possible with a very inaccessible area. That's why I'm just sharing this. In the sense, zygomatic under local anesthesia is an inaccessible situation. More like the pterygoid also is an inaccessible situation. But if you plan them, then you can create a guide which helps you to position your pterygoid implant most ideally. So this would be the most ideal position of the implant. You create a guide which is either taking support from a tooth or some anchorage of the bone, and then you have the exact path directly for the pterygoid implant to go and land itself in the exact location that you want to land, or touch the medial pterygoid plate or whatever have you. We can also create guides for any other procedures like, say, an apicectomy if you want to do. So here you see this is a molar, and we don't want to mess with the inferior alveolar canal here. So we need to create, this is the inferior alveolar canal. So we need to create an apicectomy for this guide for this molar, so that we just remove the apex of the molar alone. So this is a simple guide that you can fabricate. And once you got this, you're going to be right at the level of these two roots. You're not going anywhere else. You're not going any deeper if you stick within these boundaries. So this is how the guide fits inside the patient's mouth. We use a small piezo device, and we can create a window. Once we have created a window, then we have access to the roots. We can cut the roots off with, again, another piezo, or with a burr if you choose to. And then you have this window taken out, and you have just the apex of that tooth removed as well. We can also make guides for what are called as socket shields. The labial cortical bone in most patients is hardly about 0.75 mils, which means when you extract the tooth, that particular cortical crest will resolve, and you may get recession. So there is this concept that you preserve a small part of the dentine, or part of the tooth is left over, just like a dentine graft, and then you position the implant behind it so that there is hardly any resorption of the labial plate. So we can plan a guide very well for that, and this is how we do it guided. So we just make this area, we remove the GP, and then we just section the palatal portion of the tooth, the small labial portion. So you get a small labial dentine that's still attached to the labial cortical plate. So when you place your implant, you can place your implant there. That is their dentinal portion there, and then you make a provisional. So the patient goes with their own natural tooth, cut up and used as a temporary, and then you have hardly any breakdown of the labial plate at all, hardly any recession, which means in patients who have a high smile line, this is a great service that you can do. The other thing that you can look at is about if you see here, there is so far what you have seen are static guides. You have dynamic guides like navigational surgery, but now you also have hybrid guides. So like this is a hybrid guide where you make a simple guide But this is just a device. You don't have a very big GPS monitoring system in your office. It's just a very simple thing which attaches to the handpiece, and there is a SIM card like device on the patient, on the surgical guide, which you fit into the patient's mouth, and you can go ahead and you can exactly pinpoint the 3D position of whatever you're doing. So you have the 3D position pinpointed. So even if the patient's mouth opening is small and you can't use the guide in place, here is just like a regular implant. You're just doing this like a regular implant, a very small device attached. It's not heavy at all. And I think it's going to, at least in partially edentulous cases at the moment, it's going to take the industry someplace. And what you see here is is a robotic arm, which is actually placing the implant itself. This is real life dentistry today. There are so many robotic companies which have devised robots which can three-dimensionally navigate themselves into the most appropriate position that an implant should be. So that even a senior, well-qualified, experienced implantologist can be left just holding the suction. We never know. So, I mean, recently I looked at something called, like a robot called Optimus, which is developed by Tesla. It's a very good possibility that people will have clinical assistants who are basically Optimus robots. And if the number goes up, it can be available anywhere from $20,000 to $30,000, which is not too bad amount to have a one-time expenditure for an assistant. Anyways, so that's a short story about what digitalization has taken us in the year 2024. This is my small team of people whom I work with who do the digital planning and fabrication of all the guides in our practices, and of course my own surgical team, which helps me accomplish whatever I'm going to accomplish. I thought I'll share a small moment with you about this particular program. I'm a faculty at the Indian School of Business in Hyderabad. I'm an adjunct faculty. And we're running a special program on leadership and business excellence in dentistry. Anybody that is interested can actually contact Sriram on this number. And I think it's a great opportunity for young dentists to learn how to manage a business, which is something that we have not, ever been taught. I've shared this with Dr. Manik Vaskam also, and I'll be happy to share with you whenever you want. So thank you everyone for this wonderful opportunity. I'm so happy to be a part of Dentalvriksha and being able to share whatever I can. And thank you, Manik Vaskam, once again for this excellent opportunity. If there are any questions, I'm happy to answer them now.
That was an interesting session, sir. Thank you so much. Any questions from the participants are welcome.
That is really a wonderful program, Dr. Arunachalam. Wonderful presentation. You are at a different level. And the basic doubt is we can do all the scanning and all. How to find out the best lab? Is it like trial and error only, or?
See, the labs are also very much. I'm very happy to see Venki also here. Hi, Venki. So labs are a very important element in the practice. You need to have a very, very good partnership with the lab. I feel that most of the labs are able to concentrate usually with about 20 or so dentists. So if you are continuously sending these cases to the same lab and encouraging them and also kicking them every once in a while and making sure that they cater to you, they'll come back. The worst thing for any lab is repeats. They don't want to repeat because it costs them time, it costs them money, it costs them materials. So they want to cut down the number of repeats. And for you also, you want to cut down the number of visits of your patient, and you don't want to do repeat work. So I think it's important to develop that partnership with the lab. With some people you can, with some you can't. They may be good for some dentists, may not be suiting your profile. So that's an important element. But I think with time, we'll all settle down into some mutual symbiosis with the lab. I don't know how else to explain this. I mean, fortunately for us, we have our in-house, some of the thing we do in-house. And I've also partnered with the lab. I supply them with materials. I supply them with equipment. So they do things for me at, reasonable price and reasonable speed. So that's not too bad. So it's just that you have to develop that relationship with the lab.
Okay, Dr. Venki has a question, I think. Dr.
Yeah.
Venki, please proceed. Dr. Venki, you can unmute yourself and then you can ask a
Yeah,
question.
yeah, yeah. Thank you, Arun Boss. Wonderful lecture. I'm privileged to hear this from you from the conference as well. My question to you is: it's really scary that you told that good old surgeons will be holding the suctions in the future. So, what you think in due course of time or in another 10 years of time, what you see, how this digital dentistry or digital
Yeah.
things will move?
Yeah.
What all
I
the
mean,
things can
I,
happen?
I understand. I know where you're coming from. I mean, I actually literally saw this happening. The robots are basically doing the procedure, and the dentist was just, not one and two extra. They're just holding the section and, watching things unfold. So that is one element. Uh, See, one thing I'm very sure, dentists who get into computerization, digitalization, and AI will definitely be far better than dentists who don't get into it. Okay, so that distinction is very sure. Everybody will have to get in at some level, to enhance their level of practices. That's very important. But in terms of skill, um, there are still certain skills which rest with you. And as an experienced practitioner, you will realize that you do have certain skills. Uh, I was just talking to my anesthetist the other day, and she was so, saying AI is taking over this, AI is taking over that, monitors are taking over everything. I said, doctor, still today, I don't think any robot can intubate like you can do. So it's just that, there is a certain clinical skill that rests with you, and it's important for us to hone those skills. It's also important for us to understand that our level of thinking and our level of being able to solve problems without actually using too much logic, that capacity for us is very huge. So which means that our intuition and many other things are still with the human being. Okay, that is also changing in the sense, there are psychiatry AIs which actually talk to human beings like an emotional being. I don't know if I'm able to make sense. Okay, well, what does a counseling mean? A counselor is something you have a human interaction with. You are a psychiatrist, somebody that a patient wants to have human interaction with. That itself is now getting covered under AI. So if AI becomes emotionally intelligent, I think that's a problem. But so far, I think we are okay. I don't know how long that will last.
Thank you. Thank you, boss.
Thank you.
Any other questions, please? And was what about the socket shield technique?
Yeah.
What about the bone anchorage in the labial part? Like the in the other portions, there will be a good osteointegration, except
Yes.
the labial part. So will
Yeah.
that affect the implants?
You're very correct. You're very correct. Actually, there is a space between the dentine graft and the implant outer threads. The implant outer thread is not contacting the dentinal graft. There is a space between them. So normally that space is filled with blood clot, and we put some graft material. So the graft, usually we will put tricalcium phosphate, which resorbs and turns into bone much faster. So the implant is never in contact. We make that surface concave. The implant is never in contact with the dentine fragment. It is just that there is blood clot and graft material there. So that is still osseointegrated. One another thing, if you want to call an implant osseointegrated, you only need 60% of that implant surface to be integrated.
Okay.
60% if it is covered in bone, that implant is an osseointegrated implant.
Okay.
So this is mainly, in aesthetic areas, high smile line, those areas we represent.
Okay.
As an extension of this, we also do what is called as a tooth graft. Like if we extract an impacted tooth, we can cut the crown off and we actually powder that dentine. we treat it a little bit. There are a couple of solutions with which you treat them, and use that as a graft into that socket where we extracted tooth. And it has phenomenal results. Like if you do a canine impaction and you take the canine, grind it up and put it there, you'll find that the bone that forms there is almost indistinguishable from the bone anywhere around the area. So dentine actually works as a very good graft material.
Okay. So I think people will ask questions in the group later.
Sure.
And many people are already messaging me to get the video in the YouTube because they are
Right.
outside, and I need a permission also to post it in the YouTube.
Sure. Go ahead.
Yes,
Feel
thank
free.
you. Thank
Yeah.
you.
If
Thank
there
you.
are any questions, I'm more than happy to answer even on the group later
Sure.
on.
Yes, boss. Thank you.
Okay.
Dr. Manasa,
Good.
please.
Thank you so much, sir. I extend my thanks to you from the entire Dentalvriksha team. Thank you for the wonderful presentation, sir. Thank you for all the participants for coming here for learning anything new. Thank you so much.
Thank you, boss. Thank you so much.
Bye. Thanks.
Bye.
Bye. Bye. Bye. Vic.